Welcome, everyone, to another exciting episode of the CNS Journal Club podcast. My name is Brian Saway, and I'm the fourth-year neurosurgery resident at the Medical University of South Carolina. I have the pleasure of organizing and hosting this February edition of the podcast. We have a great group of guests joining us today to discuss this newly published article in the Red Journal, Global Outcomes for Microsurgical Clipping of Unruptured Intracranial Aneurysms, a benchmark analysis of 2,245 cases. To get us started, I'd like to have our guests introduce themselves. First, we are privileged to have the senior author of this study, Dr. Duhrsen. Dr. Duhrsen, do you mind introducing yourself?
No, not at all. Thank you for having us. It's a great pleasure. So yeah, my name is Lasse Duhrsen. I'm a senior consultant at the Department of Neurosurgery in Hamburg, Germany, which is in the north of Germany. And my subspecialties are neurovascular surgery and neuro-oncology.
All right. And for this edition of the podcast, we're fortunate to also have the first author of this study, Dr. Richard Drexler, joining us today. Dr. Drexler, do you mind introducing yourself?
Yeah, thank you so much for the kind introduction. I had been the pleasure to work with Lasse Duhrsen on this fantastic study, I guess, in the past years. I had been working for 2.5 years as a neurosurgical resident in the department of Lasse Duhrsen, also in Hamburg, Germany, and moved recently last year to Stanford to focus on some research and doing a postdoctoral fellowship in the neuro-oncology field. But yeah, as said, I had been the pleasure during my time as a resident to work on some cerebrovascular studies, and I think this was the main output of my research time.
Great, I'm glad to have you. And last but not least, we have the venerable Dr. Alejandro Spiotta on the podcast as a guest interviewer. Dr. Spiotta, do you mind introducing yourself to our listeners?
Absolutely. So Brian, thanks for the invitation, as well as the CNS Journal Club podcast group for the opportunity to join you guys. And Dr. Duhrsen and Dr. Drexler, I look forward to learning from both of you. So my name is Alex Spiotta. I'm a neurosurgeon, and I head up the neuroendovascular division in Charleston here at the Medical University of South Carolina, also the vice chair of the department. And I also have a keen interest in international registries and data sets as the PI of the STAR network, the stroke thrombectomy and aneurysm registry. So really excited to see this paper has been selected. I look forward to the discussion. Again, thanks for having me.
Thank you all for your introductions. So today we have an internationally renowned group here of both open and endovascular neurosurgeons to discuss this pertinent topic of benchmark outcomes for clipping of unruptured aneurysm. I'd like to start with Dr. Duhrsen and Dr. Drexler. Could one or both of you please give us the background behind this study and just taking us through the key findings of the article?
Sure, I can go ahead and give a bit of background on the paper, so everybody can understand when we're talking about in the next maybe 30 or 45 minutes. Basically, the key aim of our study was to establish, as the title is saying, global outcomes for microsurgical clipping of unruptured aneurysms. We applied a concept called benchmarking, which aims to improve surgical outcomes and tries to standardize the outcome of patients by introducing reference values. The whole concept is basically introduced by a group of general surgeons from Zurich, Switzerland, a couple of years ago, and got a lot of attention in the past years. And so we try to establish this concept in the neurosurgical field for the first time. We collected retrospective data of patients who underwent microsurgical clipping of unruptured aneurysms, and collected data from 15 centers worldwide, including, I guess, from four continents. The whole concept is based that the patient's cohort is divided into low risk and high risk patients. So the benchmark outcomes, the reference values, are described on the lowest patients, the so-called benchmark cohort. And basically that's the way we did it on these on this data set from the 15 centers. Overall, we included 2,245 cases of patients who underwent open treatment. Of these roughly 2,000 patients, 852 were categorized as benchmark cases, so being a low-risk patients, and were the patients we established these benchmarks and reference values for several outcomes. We described a lot of post-operative outcomes up to follow-up time up to 2 years. I think to briefly summarize the main important outcomes, we looked into favorable neurological outcomes described by the modified ranking scale, with like achieving, or patients achieved roughly about 96% this a good neurological outcome after surgery. Also we described a general post-operative complication rate, in hospital mortality, which is comparably low as expected after elective surgery. Also length of postoperative stay, of ICU stay, which we would, I think, going to discuss later in the podcast. And I think most importantly, we also described the aneurysm closure rate, which was seen in, or the benchmark was set as 97.1% as discharge, and increased up to 98% at a 1-year follow-up. So it's a long list or a long table of different outcomes, which should just guide other centers, other registries, to look into an international cohort and to compare their own results with these reference values to see if they can match these reference values, or if there is room for improvement in their own, for example, in their own department or in their own country, whoever is the person who compares to our data. So yeah, in summary, I think our study presents internationally applicable benchmarks, reference values for the most important outcomes after microsurgical clipping of an unruptured aneurysm, which could serve as reference values to other centers and registries, and also for future treatment modalities, comparing open or endovascular techniques.
Thank you, Dr. Drexler, and thank you for publishing this very timely data in this rapidly evolving field. Your paper certainly brings up a lot of discussion points. I'd like to start with Dr. Spiotta, if you happen to have any questions for the authors.
Absolutely, absolutely. First of all, my congratulations on this great work, and I just want to underscore the importance of having these sort of large studies that remind us to continuously check our outcomes. And Brian, you alluded to this rapidly evolving field is what you call it. That's exactly what it is, in particular with aneurysms, but really anything in neurosurgery this can be applied to. There's always new techniques, new technology. So there's always a little bit of a conflict or a balance that must be maintained between exploring new avenues while ensuring the best possible outcomes. So having data as a benchmark or reference is very important for our own analysis. So I would recommend that we all have these data sets available, and also I would encourage everybody to have your own personal data sets. So how's my institution? How is my group? What's my practice? Are my MCAs better repaired surgically or endovascularly? And that's always a difficult conversation to have with yourself, but that's something that you must do, especially, like I mentioned, rapidly evolving, but also your practice may also evolve over time. So having subjective objective data that you can lean on is extremely important. My first question to the authors is, of course, the data is retrospective and multi-center. It's a large data set. I think the biggest bias, and I want to ask you how you think we should manage this bias, is we're getting the data we're getting for the ruptured, for the surgically treated aneurysms is those that the centers and the operators at the centers did not want to treat endovascularly. And that's going to be, physician dependent, center dependent. So there's some bias there. We're seeing a selected group of patients. So walk us through, how do you think we should evaluate or weigh the data and the results based on that bias that may be present?
Yeah, I think that's a great point. We discussed this point several times before, planning this study, and also when we analyzed the data. We tried to tackle this to when we defined with our definition for including some centers, we only included departments or hospitals which have the possibility for open and endovascular treatment. So and also make the decision for going for open or endovascular surgery in an interdisciplinary conference. So I think this standard needs to be reached, that there are openly trained neurosurgeons, but also endovascularly trained neurosurgeons or neurointerventionalists deciding what's the best treatment for the patient. And I think that was one of our main points, that every department, every center included in the study is able to treat in both ways. The other point was, as an inclusion criteria, that centers need to be able to have an neurologically or neurosurgically specialized intensive unit care, just to see that every department is able to treat any kind of aneurysms, and that there are no let's say exclusion criteria for the patients. And that was the way we tried to tackle this. We also collected just the number of cases in each department during the same time period, which were treated in the endovascular technique, which was not influencing at least the range of or the proportion of benchmark patients. So we try to tackle this with our inclusion criteria, but I think it's best way we could have done it, but it's a very important question.
Absolutely, thank you. And were there any results? I don't know, Brian, if you're going to show some of the results.
Yeah. Here, let me pull up. We can pull up the benchmark results here.
Yes. Yeah. So that's basically representing all of our benchmark outcomes, which are calculated as we take the low risk patients. We calculate the median of each center, and then, as previously defined or described in the literature for this benchmark concept, we calculated the benchmark cutoff as the 75th percentile of all these centers median. So basically this, I think, or in my opinion, that's a good concept, because every center participating in this study and every center who gave data to this study is represented in the same way. So there's no bias in that one center is including, for example, 500 patients, another one is including 150. So they are represented in the same way, given that the quality based on our inclusion criteria for the centers should be the same, hopefully.
Yeah, Dr. Drexler, I'm going to go back to here, to this figure here, and this was your establishment of this benchmark criteria. I think it's just a very clever way of trying to establish this homogeneity of data, to try and establish this benchmark or ideal cohort of patients so that we can establish that homogeneity. And I think this translates to all aspects of neurosurgery in an evolving field, where we're taking data from different centers together. This allows us to share data and again, establish that homogeneity. I wanted to go back to this and and go over the benchmark criteria that you guys established, and what was the process of establishing these certain parameters?
Yeah, great point. At first, it was a long process to establish these benchmark criteria or to define it. The recommendation by the Zurich study group was to define these benchmark criteria for each procedure. In our example, for the aneurysm clipping, based on the current literature. So we searched in the literature for, in the best case, meta-analysis. There's one in JAMA published a few years ago, I think in 2017, which helped us a lot. But based on the current literature, we just checked which parameters, for example, the known factor, posterior circulation or higher age of the patients, which are known to just negatively affect patients' outcome after clipping. And that was the process. It's all based on published data, which is kind of varying in the evidence, to be honest. That needs to be mentioned, I guess. But it's based on existing and published data.
Got it. Thank you. The next figure I wanted to bring up was this figure 1. I know Dr. Spiotta talked about managing some of the biases amongst the centers. I think here where you, it's a great figure that shows all the centers, the proportion of benchmark cases to non-benchmark cases, and also the proportion of cases that were treated with clipping. So there is some heterogeneity between these international centers. Certainly a center that does 500 aneurysm clippings in a 4-year period, where half are healthy benchmarks. Patients surely has a different experience than one that does 50, where only a handful are healthy benchmark patients. Do you believe that this disparity impacts the homogeneity of the data, and should some of these outliers be omitted to better reflect a real-world international experience or expectation?
Yeah, that's such an important aspect to discuss, and I think it needs to be acknowledged to the readers or by the readers that we have centers with a very huge variation in the number of cases treated. Also, when you see it's in the light blue, the percentage of benchmark cases, we have a variation between, in Center 1, for example, 16% had been benchmark cases, up to nearly 50% in Center 15. I think that shows the variation between the centers treating low risk or high risk cases. Nevertheless, this range between the percentage of benchmark cases is quite is actually matching all other previous papers describing benchmark outcomes. Not in the neurosurgical field, because this wasn't introduced for neurosurgical procedures before, but for general and transplant surgery. So every other study had seen this variation in their analysis. I think one thing to mention is that we for calculating, I think I mentioned it before, for calculating the benchmark cutoff value, every center is having the same weight. We just calculated the median of each center. So basically, the importance of Center 1 is the same as Center 15. Nevertheless, it needs to be acknowledged that the experience is certainly different, I guess, in a center which treats 500 cases in a 4-year period compared to 50 or 70, I guess, cases in the same period. Needs to be acknowledged. I think that's the best way to mention it. We had our inclusion criteria for the centers, which I introduced before, and we didn't know beforehand how the proportion of benchmark to non-benchmark cases would be, or how high the number of open treatment patients would have been.
Yeah,
but yeah, that's a great point to mention, I guess, for everybody.
Yeah, I guess the thought that I'm having now is potentially to dilute that effect. Could you have included more centers? Of course, that makes the logistics of organizing everything more complicated, but is that something that you all considered?
Of course. So this I could answer perhaps.
Mm-hmm.
So, but there's this definition of how you should prepare this kind of study for benchmark studies, and it actually says that you need different centers from 3 different continents, and so of course your data gets more valuable the more centers you have, but it was even tough to get these 15 centers,
right.
and so we were actually quite happy.
Yeah, no, I think getting 15 centers to come and collaborate together is a pretty incredible feat. So the next, I wanted to bring up this table that has the really the benchmark results that you guys were able to share with the neurosurgical community. Dr. Spiotta, I wanted to open it up to you. Was there any results here that stood out to you?
Yeah, absolutely. I think as we took a look at these benchmarks, I think the length of stages looked a little bit longer than I would have expected. I think the durability aneurysm inclusion was extremely high, and I think that was not a surprise. I think those are my main initial reactions. Dr. Duhrsen, Drexler, what were your thoughts? Anything that surprised you?
Yeah, I think the length of hospital stay is one of the main or the mostly discussed parameters. Had been the most discussed parameter in our group, with like a benchmark of 7.7 days. I think that is for some of these outcome parameters, and especially the length of hospital stay, or maybe also the length of ICU stay, is highly influenced by the different healthcare systems. When a bit looking into the data stratified by continents or by countries, we saw a significantly longer length of hospital stay in European countries, which is due to the different healthcare system when compared, for example, to the US or to North America. It's highly biased by it, and it needs to be mentioned. I think the length of hospital stay, when just looking into North American hospitals, would probably like 2 days. It's highly different in Europe, where you could be fined when the patients are staying too short, which is, I think, quite a ridiculous fact, but that's the way it is. So especially length of hospital stay is mainly driven by the healthcare system of our included countries and centers.
Got it. Makes sense. So yeah, regional practice, and that's the strength of having such a diverse and broad number of sites contributing to cases. Now, something I was curious about, Brian, on the previous slide, I was looking at the experience of the various centers, and specifically by volume and higher volume centers. I think what surprised me, I was expecting in the higher volume centers to be taking on more complex cases, which I would have expected, but not necessarily to be reflected in non-benchmark cases, a higher percentage of non-benchmark cases in the higher volume. And there's a lot of information on this graph. There's the volume percentage, of benchmark cases and the percentage of, clipping over all the aneurysm treatments. But I wasn't seeing the trend which I would have guessed. Again, the higher volume taking on more higher complexity cases, non-benchmark, higher risk. So I just want to get your reactions to that.
I think what this reflects is it's just that the endovascular treatment is just getting better and better, even for complex aneurysms. So I think that is what we actually see here.
I see.
Maybe
Awesome.
to add, sorry, excuse me.
Go ahead.
just maybe to add, I think it's fair to mention that you would have expected that, because it's when you take a look at the existing benchmark papers for general surgery, which is mainly focused on pancreatic and liver surgery or transplant surgery, you can see that higher volume centers are having a lower percentage of benchmark cases. So they're fairly treating higher complex cases or patients, higher risk patients. But I think we're in a different, probably the cerebrovascular aneurysm field is a bit different than it is for liver or pancreatic surgery. And I think that's why the mentioned reasons from Lasse Duhrsen are valid for this, maybe for this explanation that we're not seeing this trend in our graph.
And then one last question. I know that it wasn't the focus of the study, but did you see some signal regarding high volume centers and achieving these benchmarks at a higher rate, or having better parameters in those benchmarks?
Very, very important question. We are currently a bit digging into deeper into this question. We could see for a few outcomes a certain trend, but that wasn't very significant. So we're not reaching a significant p-value, and for most of the parameters, for the outcome parameters, we cannot conclude that our centers with a higher volume are offering a better treatment or better quality. So I think that just highlights that it's fair to say that all of our included centers are treating on a same quality, more or less, and the inclusion criteria or the benchmark criteria are applicable and valid. But yeah.
Yeah, I have another question. So we keep bringing up this concept of this field evolving, specifically with vascular neurosurgery, with endovascular techniques evolving so quickly. We have this adversarial clipping versus endovascular debate that is simultaneously evolving. We're now seeing a shift of focus to developing centers that have both open and endovascular capabilities and can provide a patient-specific approach to unruptured aneurysms. Do you think that the assessment of the efficacy of aneurysm treatment should continue to stratify outcomes based on microsurgical clipping versus endovascular treatments? Or should we begin to stratify outcomes based on centers that have a balanced availability of interventions versus centers that have a favor for clipping or endovascular treatment?
Well, thank you for this very good question. So from my point of view, this we certainly need both disciplines. Yeah, we need the strong endovascular surgeons, but we also need the microsurgical surgeons, and it's a bit different in Germany, at least, than in the US. I know that we have in Europe, like in the Netherlands, there are dual trained neurosurgeons who do both, and in the US you have it as well, and we don't have it, but for example, in our department, we do it the way that we discuss together every cerebrovascular case, and then we decide not by who sees the patient first, but who can treat it best. and then we decide who treats the aneurysm or the vascular pathology. And I think that's a very good way, and it's the best for the patient outcome this way. So, but on the other hand, I can't comment on how a dual trained surgeon would do it.
Yeah,
Got it.
maybe
Thank
adding for specifically for this benchmark outcomes. I think we're not there yet to maybe establish benchmark outcomes for like the balanced availability of endovascular and microsurgical treatment. I think it's fair to say that it's a good first step to have the benchmark outcomes, the reference values for the open treatment by now, to compare future techniques and maybe approaching it in the next years to combine open and endovascular, to have maybe a combined benchmark outcome. That would be the ultimate goal, I guess. But yeah, I think it's good that we're starting at least with a clear open technique for now.
Got it. Thank you. We're getting close to needing to wrap up. I do have one more question. First of all, thank you for bringing this concept of benchmarking to the field of neurosurgery. I think, like Dr. Spiotta mentioned, it's so important that we look at ourselves internally and establish these benchmark parameters so that we can make sure that we're pushing ourselves to better help our patients. My question is, when do we relook at this? When do we bring out the next version of benchmarks? How often do you think we need to internally evaluate ourselves?
Yeah, that's a very, very important question. From my point of view, or my wish would be to do it every 5 years. I think that might be impossible to get all the data from every center every 5 years. But I think there needs to be a specific time frame, for example 5 or 7 or 10 years, to revalidate the benchmark outcomes. I think it's an emergent field, and I think the indications might change in the next years for open treatment. So my goal would be to revalidate every 5 years, at least, or maybe the next time with more than 15 centers. But it was tough to get all these data and to get all these centers on board this time. So I know it's going to be a challenge in 5 years again to get the data.
Sure. Well, I can only imagine the difficulty of getting this all, and I want to congratulate you all again on this incredible article. I know the entire neurosurgical community is very thankful to have this new established benchmark. But with that, I think we have to wrap up. We're at time now. I want to thank our guest, Dr. Spiotta, and our authors, Dr. Duhrsen and Dr. Drexler, for joining us today. It's been an incredible discussion. And again, for the listeners, I want to remind you that the CNS podcast activity is available to claim for 1.5 CME credit by visiting the podcast page on cns.org. And I would love for you all to join us next month for the next Journal Club podcast. And thank you, and have a great day.
Thank you. Take care, everybody.
Thank you.